Dr. Mark Lebwohl is a clinician and researcher. He has been working on PXE for decades and has completed one of the few clinical trials on PXE. We're delighted to hear from him today about that trial.
Thank you very much, Samantha. So by way of introduction, my name is Mark Lebwohl. I'm chairman of the Department of Dermatology at Mount Sinai in New York City. And PXE became an interest of mine very early in my career. In fact, I had something to do with my becoming a dermatologist. I was going to be a cardiologist and had never taken a dermatology rotation. And when I did my first dermatology rotation at Mount Sinai, I saw an 8-month pregnant PXE patient who had a very loud heart murmur, which caught my interest. And we ended up finding about 18 other patients with PXE, and about 2/3 of them had that same heart murmur. We reported that in the New England Journal of Medicine, and ever since then, PXE has been a large interest of mine. At this point in my career, I've seen well over 1,000 patients. Actually stopped counting many years ago. And we have done several trials in PXE, and I'm going to speak to you today about a magnesium study, and I'll tell you why we picked magnesium and the results of that trial, which finally are published. They're available online in the Journal of the American Academy of Dermatology. So before I start, there are a few people I truly have to thank. One of them is Sharon Terry, and I'm just going to say this. When the day comes that we actually have a very effective treatment for PXE, and I believe that day is very nearby, Sharon will have had a lot to do with it. In fact, all of the effort that's gone into PXE we could not have done. We could have not recruited the patients to help us find the gene in PXE, for which we have Yoni Wido to thank. And again, an extraordinary scientist who's dedicated his life to answer questions about PXE in the lab that then translate into clinical benefits. We couldn't have found the gene without Sharon and without Yoni. We could not have filled any of our studies without help from Sharon. And a lot of the credit for all of the work that is coming out now goes to her. But even more importantly, the credit for the treatments that are coming very soon should go to her, because she's the one who really stimulated everyone to do these, got the patients, raised the dollars, did everything that it takes to get this done. So a big thank you to Sharon Terry. I also want to thank a couple of clinicians. One of them is Howard Berkowitz, who's at Brown. And, nobody ever got rich taking care of PXE. Howard is a board-certified ophthalmologist and dermatologist, and has made this a focus of his interest and has contributed greatly to what we know about PXE. And Wayne Fuchs, who's in my neck of the woods, he's a retina specialist in New York City, who is just extraordinary. I mean, he volunteers all the time. He is better at finding the ocular manifestations of PXE than anyone I know, and has just been a real hero of the field. So I want to thank the four of them for all that they've done to forward our progress in PXE, and that is going to happen soon. So this is a picture of Mount Sinai. We now take care of about half of New York City. We have 4 main Manhattan campuses. This is where I work, and this is the view from my window. So here's a patient with PXE, and I'm going to tell you about how we stumbled on magnesium here. And all of that started when I already was doing a lot of work in PXE, including a lot of basic research and clinical work. And we saw a patient on the consult service at Mount Sinai who had an entity known as periumbilical Pseudoxanthoma Elasticum, which is a common place to get PXE. And some patients with renal failure just have what looks like periumbilical PXE, but this patient also had angioid streaks, telling us that this patient most likely had true Pseudoxanthoma Elasticum. And she underwent dialysis, and her skin disease cleared. And we tried to figure out why that would be, and we realized that when patients are put on dialysis back then, this is in the late 1990s, we used a phosphate binder called Amphogel. So we thought, from a logical point of view, here's a drug that reduces phosphate. The product of phosphate and calcium in the blood is always kept constant. So how do they replace the phosphate there? And our reasoning was they must take the calcium out of the skin lesions. And so we decided to do a study of oral phosphate binders in the treatment of PXE. We did a small number of patients. It was an open label study. And we did skin exams. We looked at skin evaluations and photography and a skin biopsy. We had only 6 patients, but 3 of the 6 improved clinically. And all 3 of them showed improvement under the microscope, and their eye disease was stable. So we thought, it must be the aluminum hydroxide. So we then entered into a trial of oral phosphate binders. Now, by this time, Amphigel had been removed from the market, not because of anything dangerous, but because it just wasn't a big seller. As far as I know, was the reason it was removed. And the one that became the phosphate binder of choice in our dialysis unit was Renagel. So we thought we would try that. And this time we did a real study, double-blind, placebo-controlled. We gave either 800 milligrams of sevelamer hydrochloride, which is Renagel, 3 times a day, or placebo, and in a 1-to-1 ratio for a year. So patients either got placebo or the Renagel. The second year, we gave just the Renagel to everyone. And we did skin exams. We picked a target lesion, and we did 2 biopsies, skin biopsies, at the target plaque at baseline, and then at the end of the first year, which is the blinded year, and then again at the end of the second year. And the main endpoint for us was going to be calcification of elastic fibers as measured by computerized image analysis. When you do a skin biopsy, Von Casa stains calcium black, and normally a skin biopsy, the dermis is pink. So it's very easy to distinguish those. And we did some other testing as well, and we did do ocular testing, although that is a little more difficult to get an endpoint on. So the primary endpoint was calcification of elastic fibers on skin. We enrolled 40 patients, 20 in the placebo group, 20 in the Renagel group, 2 in each group dropped. And that's, considering a 2-year study, to have only 10% of the patients drop out is extraordinary, and it's a testimony to the dedication of PXE patients to find a treatment for this disease. We created a numerical grading scale of the target lesions, which range from 0, which is no PXE, up to 9, which is severe PXE with redundant folds of skin. And, in the middle there, we had macules, which are flat yellow lesions representing the lower end. We had papules, which are small elevated lesions representing the middle end, and plaques, which are patches and plaques, which are large lesions representing the upper end. And then we also we gave clinical scores for the disease based on those numbers. And what we found is that in the placebo group, at the end of 1 year, there was perhaps a 2% reduction in the clinical scoring. By the end of year 2, when they were already getting some Renagel, there was a 14% reduction. And these are the clinical scores. So this is done by eye, by the investigator, who doesn't know if the patient is getting Renagel or placebo the first year. The second year, everybody gets Renagel. In the active group, the reduction was a little bit more, 7% at year 1, 19% at year 2. And those numbers, actually, those differences were indeed statistically significant compared to baseline. If you looked at the number of patients who got better or worse, the numbers are very small and not very different from the placebo to the Renagel group. We had 11.1% get worse in the Renagel group, 16.7% in the placebo group. Improvement was actually higher. It was 72.2% in the placebo group, 83.3% in the Renagel group. And we really couldn't explain why would patients in the placebo group improve. The more important number is what we found on calcification of skin by image analysis. And you can see here the differences between placebo and Renagel are very small and not statistically significant. Compared to baseline, there's actually a larger reduction in the placebo, 41.93% at the end of year 1, compared to 38.37% in the Renagel group at the end of year 1. So, those numbers are virtually identical. And we had difficulty explaining this. And, we actually viewed this as a negative study. So it works on humans, but we don't know about mice. Then a few things started to happen that explained to us what might have taken place. Dr. Guido developed a knockout mouse. By then we had discovered the gene responsible for PXE, the ABCC6 mutation. He knocked out ABCC6 and developed a mouse that essentially got mineralization of calcification of elastic tissue just like people get. When those mice were given Renagel, it did not improve the calcification. But when they were given magnesium, it prevented the calcification. And they also showed that mice who were placed on diets that are high or low in phosphate didn't impact calcification at all. But when they got a magnesium-enriched diet, 5-fold enriched, they got no calcification. So it looks like magnesium would be the magic solution. And there were several other publications showing that magnesium carbonate prevents connective tissue mineralization. And if you increase the magnesium in their diet 5-fold, they completely prevented mineralization. Again, our study was sevelamer hydrochloride 800 3 times a day versus placebo, and the second year was open label Renagel. Well, it turns out sevelamer hydrochloride contains 160 milligrams of magnesium. So we didn't know that when we were giving them Renagel, we were giving them magnesium. What really took us by surprise is we had no idea that the placebo had magnesium in it, 400 milligrams, more than the Renagel, which explained why the placebo patients would have gotten better. So this came as a complete surprise to us. So we thought we were really onto something here. And again, other papers came out pointing to the fact that magnesium, not calcium, prevents vascular calcification in mouse models of PXE. Raising the calcium, and for many years, we were taught that patients on high calcium diets had worsening of their PXE. Well, it turns out in these mice, raising the calcium in the diet had no impact on the disease severity, but increasing calcium and magnesium slowed down the calcification. And other studies, again, showed that magnesium reduced, for example, intima thickness of the carotids in a mouse model of PXE. And other soft tissue calcifications were also treated with magnesium. So we proposed this study, which was approved. It was funded by the FDA and NIH. And it was a double-blind, placebo-controlled trial of magnesium oxide 500 milligrams twice a day versus a placebo that we made sure would not have magnesium. We enrolled 44 subjects, and half of them got magnesium, half of them got placebo the first year. The second year, they all got magnesium. The inclusion criteria were typical inclusion criteria, but the important points here is they had to have at least mild disease at screening that was visible. We excluded them on a basis of other health issues, and the investigations that were done were, first of all, a skin examination. We picked a target lesion and performed biopsies, as you will see. So the objective was the primary goal was to look at the role of magnesium oxide supplements on reversing elastic fiber calcification in PXE. Again, 44 patients were enrolled. It was double-blind, placebo-controlled. They either got 1,000 milligrams of magnesium or placebo. And at year 2, everybody got 1,000 milligrams of magnesium. We took 4-millimeter punch biopsies at baseline, and after the first blinded year, and then after the second year, open label year. At the end of the second year, which was a secondary endpoint, we wanted to see if the calcification of elastic fiber reduction continued. And at the end of the first year, in the year where we didn't know if the patients were getting placebo or Renagel or magnesium, we wanted to see if we indeed caused a reduction in calcification of elastic fibers. The dermatopathologist who assessed the calcium levels on the skin did all 3 years at the same time and did not know who had gotten what and what year he was looking at. So it was done in a truly blinded fashion from that point of view. And just to give you an idea of how easy it is, the calcification was judged as a grade 1, 2, or 3. And you can see the Von Casa is dark, the background is pink, and you can see the difference between mild, moderate, and severe. And here's the scoring again. None is 0, mild, moderate, and severe are 1, 2, and 3. And we use the same clinical scale to assess the lesions individually from 0 to 9, with 0 being no evidence of PXE, 9 being severe PXE. We also did do eye exams, and we did bone densities. And the eye exams were typical eye examinations, including a regular evaluation, color fundus photography, optical coherent tomography, which gives us a good look at the retina, and ICG staining, which was optional. And here's the result. And if you look in the upper right-hand corner, which shows very well the primary goal, the line that says 0 means there's no change. The positive numbers means the patients got worse. The negative numbers means the patients got better. And every bar that you see here represents one patient. And the red bars are patients who got placebo. The blue bars are patients who got magnesium. And just an overall look at this, especially in that upper left-hand corner, which is the blinded first year, you see that there's much more red in the positives, meaning the patients who got placebo got worse. There's much more blue in the negative bars, meaning the patients who got magnesium got better more often than the placebos. The lower boxes represent what happened over 2 years. At this point, the patients are no longer blinded, but that was the 2-year measure. So let me say up front that what we're looking at here is called the post hoc analysis, meaning we didn't determine in advance that we would use 30% reduction in calcification as our cutoff. But when you go through every level of calcification reduction cutoff, the magnesium beat placebo at every single level. But at 30%, the differences were greatest. So for example, if you use the 30% reduction in calcification, 8 out of 21 magnesium patients had a reduction in calcification compared to only 3 out of 19 placebo patients. So, clearly there's a difference, but because the numbers are so small, it does not achieve statistical significance. So all we can say is that there's a trend in favor of magnesium, but it is not a significant difference. And one of the problems with PXE is because it's a rare disease, you can't enroll hundreds of patients and point to a benefit. So certainly if we had gotten the same results in 100 patients, this would be statistically significant, but we only were able to do 40 patients out of the 44 who started. So the summary was magnesium had no impact on the progression of eye disease. And I will just say, in the course of this study, patients often needed to get intraocular injections of angiogenesis inhibitors. We did not interfere with their eye care at all. We allowed them to continue to get whatever they need, which of course is going to impact the outcome. So we didn't want patients' eye disease to progress, and the magnesium certainly had no impact on that. There was not a statistically significant impact of magnesium on skin progression, but patients who got magnesium had 3 times reduction of calcium versus placebo. And to obviously answer the question is we would need to do a higher dose study and a larger study. There are some more exciting molecules that are on the horizon, and these are inosine pyrophosphate. And I think that knowing what we know about that molecule gives us something even better to study, which we hope to study in the near future. So as I close, I want to make a plea to patients who have been terrific about supporting our work. We believe that we have molecules that have the potential to reverse PXE better than anything we've had before. And they're molecules that have been used safely before and are even in your diets. Some of them are given orally, some of them are given by injection, but there are a couple of them on the horizon. And we are planning to do more studies in PXE, so please stay in touch with us. I can be reached at mark.lebwohl, Lebwohl, at Mount Sinai, which is one word, MOUNTSINAI.org. Thank you very much.